My today's lesson is about Ascariasis. To start from etiology, Ascariasis is caused by the nematode or roundworm Ascaris lumbricoides. Adult worms of Ascaris lumbricoides inhabit the lumen of the small intestine, and the reproductive potential of Ascariasis is prodigious, with a gravid female worm produces around 200,000 eggs per day. After passage in the feces, the eggs embryonate and become infective in 5 to 10 days under favorable environmental conditions. And adult worms can live for 12 to 18 months. This is an image of Ascaris lumbricoides eggs, which is a soil-transmitted helminths. When we see the epidemiology of Ascariasis worldwide, it occurs globally and is the most prevalent human helminthiasis in the world. It is the most common in tropical areas where environmental conditions are optimal for maturation of ova in the soil. So it is common in the tropical areas around Asia, Africa, and South America. Approximately 1 billion persons are estimated to be infected. And the key factors linked with high prevalence of infections include poor socio-economic conditions, use of human feces as fertilizer, and geophagia. Even though infection can occur at any age, the highest rate is in the preschool or early school age children. Transmission is primarily hand to mouth, but might also involve ingestion of contaminated raw fruits and vegetables. Transmission is enhanced by the high output of eggs and the resistance of ova to the outside environment. Ascaris eggs can remain viable at 5 to 10 degrees Celsius for as long as 2 years. When we see the pathogenesis, Ascariasis ova hatch in the small intestine after ingestion by the human host. And larvae are released, penetrate the intestinal wall, and migrate to the lungs by the way of the venous circulation. The parasite then causes pulmonary ascariasis as they enter into the alveoli and migrate through the bronchus and the trachea. They are subsequently swallowed and returned to the intestine, where they mature into the adult worms. And female ascariasis begin depositing eggs in 8 to 10 weeks. Regarding clinical manifestation, the clinical presentation depends on the intensity of infection and the organs involved. Most individuals have low to moderate worm burdens and have no symptoms or signs. The most common clinical problems are from pulmonary disease and obstruction of the intestinal or biliary tract. Larvae migrating through the tissues might cause allergic symptoms, fever, urticaria, and granulomatous disease. The pulmonary manifestations resemble Loeffler syndrome, and it includes transient respiratory symptoms such as cough, dyspnea, pulmonary infiltrates, and bleed eosinophilia. And the larvae might also be observed in the sputum. Vague abdominal complaints have been attributed to the presence of adult worms in the small intestine. A more serious complication occurs when a large mass of worms leads to acute intestinal obstruction or acute bowel obstruction. And the children with heavy infection who develop acute bowel obstruction might present with vomiting, abdominal distension, cramps, and unable to pass feces in the flatus. In some cases, worms might be passed in the vomitus or stool. Ascaris worms occasionally migrate to the biliary and the pancreatic ducts, where they cause cholestasis or cholecystitis or pancreatitis. Worm migration through the intestinal wall can lead to peritonitis, and chronic infection with Ascaris lumbricoides, often coincident with other helminthic infections, impair growth, physical fitness, and cognitive development. Regarding diagnosis, microscopic examination of fecal smears can be used for diagnosis because of the high number of eggs excreted by adult female worms. High index of suspicion is the appropriate clinical context that is needed to diagnose pulmonary ascariasis or obstruction of the gastrointestinal tract. Ultrasound examination of the abdomen is also capable of visualizing interabdominal adult worms. Regarding treatment of ascariasis, although several chemotherapeutic agents are effective against ascariasis, none has documented utility during the pulmonary phase of infection. Treatment options for the gastrointestinal ascariasis include albendazole, mebendazole, or ivermectin. Piperazine citrate, which causes neuromuscular paralysis of the parasite and rapid expulsion of the worms, is the treatment of choice for intestinal or biliary obstruction, and it is administered as a syrup through the nasogastric tube. and also surgery might be required for cases with severe intestinal obstruction. The other is about prevention of Ascariasis. Anti-helminthic chemotherapy programs can be implemented in one of three ways, either by offering universal treatment to all individuals in an area of high endemicity, or offering treatment targeted to groups with high frequency of infection, such as children attending primary school, or offering individual treatment based on intensity of current or past infection. Improving education about and the practice of sanitary conditions and sewage facilities, discontinuing the practice of using human feces as fertilizer, and educations are the most effective long-term preventive measures. So for prevention, anti-helminthic chemotherapy by using albendazole single dose, for either universal treatment of all individuals in an area of endemicity, or for specific risk groups, every 6 to 1 year should be given for preventive purposes if you are living in a high endemic area. This is all about what I have regarding Ascariasis. Thank you for your attention.